Introducing Lument, a new company with a new name, one that reflects our energy and determination to redefine what you can expect from a financial partner. We've not only assembled one of the broadest product sets in the commercial real estate finance industry, we've brought together people who share a core philosophy, a philosophy that lending is more than a loan, it's a relationship.
Thank you, Lumen, for sponsoring today's webinar and for your continued support of NIC's mission. Welcome to today's NIC Leadership Huddle. Value-based care, what's in it for me? This is the 5th Leadership Huddle of our 2021 webinar series. I'm Chuck Harry, NIC's Chief Operating Officer, and I have just a couple quick introductory comments ahead of our panel's discussion. If you need to adjust your audio for today's webinar, you have joined the webinar using either your computer's speaker system or your phone based on your audio access during your most recent GoToWebinar session. You can adjust your audio access to today's webinar through either your computer speakers or your phone using the settings in the audio pane, which is located on the top of the control panel on the right side of your browser window. With that, it's my pleasure to introduce the co-hosts of today's Leadership Huddle. Amy Kaszak, President of Special Needs Plans for AllyAlign, and Jim Lydiard, now Vice President of Strategy and Development at Strive Health. Over the past 10 years, Jim led the Senior Living Solution Department at Care More Health. Amy and Jim, we look forward to your insights.
Great. Thank you, Chuck, for the introductions, and good afternoon. I'm Amy Kaszak, and I'm joined today by my co-host, Jim Lydiard. Today, we are discussing value-based care. At the core of value-based care is the triple aim of providing better care for individuals, improving population health, and reducing healthcare costs. As a healthcare industry, we've been talking about value-based care models for over 15 years, but it has really been in the past 5 years that we have started to see a relentless drive from CMS to move providers into value-based care and accompanying value-based payment models. No doubt, spurred on by predictions of national healthcare spending exploding from $3.6 trillion per year in costs in 2018 to nearly $6 trillion by sometime around 2027, CMS continues to introduce new and expanded value-based provider models. And of course, we cannot discount the role COVID is playing in the drive towards changes in healthcare policy and delivery. Healthcare providers in value-based contracts were more prepared during COVID to respond to changes in patient utilization patterns and establish new, sometimes unconventional patient pathways such as telehealth. Senior housing has and will continue to be impacted by the industry push towards value-based care. As hospitals, therapy, primary care, home health, and skilled providers adapt to new payment models and incentives, senior housing communities, even those who do not bill for Medicare services, will have opportunities to engage in emerging value-based relationships. Today, we have 3 industry experts discussing their perspectives on what value-based care means to senior housing. You are going to hear a focus on the care delivery model, and I think a slightly different take on value, with discussion less focused on alternative payment models and instead really highlighting how cooperative, coordinated, quality on-site care supports senior housing staffing, occupancy, and even overall property valuation. Jim?
Thanks, Amy, Chuck, Nick, Lumen, everybody for the great intro. Rather than hear Amy and I, bore everybody for 45 minutes, we thought a great opportunity would be voices from your own community. So what Amy and I have tried to do today is bring a diverse set of senior living type communities, a diverse set of roles, a diverse set of folks that contribute in different ways in the space to really be our subject matter experts. So We want to break things up a bit. We'll probably spend about 5 minutes at 3 different intersections of our discussion today, really discussing what value means to continuing care retirement communities, what value means to smaller assisted livings, that might be more individually owned and operated. And then also we're going to spend some time listening to the investor side. So the first perspective that we'll hear today is from Jonathan Cook. Jonathan is the president and CEO of LifeSpire Virginia, which is a nonprofit senior living provider owning 4 separate CCRCs located in the Mid-Atlantic region. Nikki, will you take it away?
My name is Jonathan Cook. I'm president and CEO of LifeSpire of Virginia, formerly Virginia Baptist Homes. I just recently started my 6th year with the organization. For those not familiar with LifeSpire, we have 4 CCRCs or life plan communities within the Commonwealth of Virginia. We have a community in Roanoke, Newport News, Richmond, and Culpeper. Additionally, we started the first CCRC Without Walls program in Richmond, Virginia. So we serve roughly around 1,450 residents on a daily basis and have about 1,000 full-time team members that help with that service. A little bit of the experience LifeSpire has had with the value-based healthcare systems is really just this last year we entered into a relationship with AllyAlign Health, also based out of Richmond, to service our clinics in our retirement community, our CCRC. And our communities are an ideal site for the value-based systems because we're already managing care transitions from independent living to assisted to memory care, skilled nursing, Medicare rehab, and home care. So what I view this as, and the reason we're excited about our partnership with AllyAlign, is we now have somebody who's actually going to tie everything together. And it's a win for our staff because we're not having to send residents out to the hospital nearly as much as we used to. What's really interesting about that, when I talked to our Vice President of Clinical Services, Paula Bolton, she told me that for every readmission, it's 5 hours of one of our nurses' time, getting the documents and the paperwork to send somebody out, and then of course bringing them back as they return from the hospital with the new orders and all of the new medications and MARs and TARs that we have to do, just the paperwork compliance. So being able to take that 5 hours, over 30% of readmissions, and put those nurses and those team members back on the floor to provide more direct care, huge win for our clinical teams. For our residents not having to go to the hospital, which is such a traumatic experience. And that, of course, trickles down to their family members, right? The people we serve. And then lastly, I think having the physician and the nurse practitioner on site on a more regular basis, treating the residents, seeing the residents more frequently, is going to create better clinical outcomes long-term for our residents. And again, that will create less hospital readmissions and better continuity of care. One of the other ways that the value-based system has helped our campuses, especially in this time of COVID, is we have more and more residents who are afraid to go out to the hospitals. They don't want to go into those doctor's offices. They really want to remain home. Again, through our partnership with AllyAlign, they have actually implemented some state-of-the-art telehealth medicine programs that is allowing our residents to be seen virtually. So they're able to get the exact same care that they would have received 2 years ago in a physician's office, brought to them in their home by nurse practitioners, physicians, and other nursing professionals. That has really created a level of comfort for our residents, and more importantly, for their families. In our retirement communities, our life plan communities, we have a clinic office. And as our residents age, it's very typical to see what we refer to as scope creep. Residents just keep asking for more and more and more. And what has happened is by bringing in this partner, we have actually put a really nice framework around exactly what the programs and services are. And what that has done is it's brought clarity. It's brought clarity to our residents. It's brought clarity to our staff. And that has transitioned to more time for our staff to provide, again, more direct care to our residents as they need it. In closing, the value-based programs that we're implementing today, I think are going to be the foundation for the future. Because as we've typically operated our retirement communities, as I've mentioned before, it's always been siloed. We've had assisted living, we've had skilled nursing, independent, memory care. And as folks transition to those levels of care, their teams, the people who have served them have always changed. By having one provider unite the care coordination on our campuses, it's going to create better outcomes better care management and better care transitions for our residents. And we believe that's going to reduce costs. It's going to reduce heartache. It's going to reduce the anxiety that those residents and families have as they age and need more care programs and services. We're thrilled about bringing these programs, and we believe we are just in the infancy stages of how these models will help us create better care transitions for the future.
So I happen to be pretty familiar with the LifeSpire Lakewood model described by Jonathan. Just to be clear for the audience, what Jonathan is talking about is a value-based care model with two important components. The first one is an embedded on-site primary care team coordinated with his community's wellness services. And these services are available to all residents regardless of payer source. And then we've coupled that with a Medicare Advantage plan that pays for expanded primary care and care coordination, supplemental benefits, and services for residents who enroll in the plan. So the primary care team, in partnership with the community team, delivers the value, and the Medicare Advantage plan pays for the value and value-added services. So value-based payments go both to the primary care team and to the community. Now, not all value-based care includes a payer plan model, but this is a great example of how senior housing communities can use or leverage a value-based payment source, whether Medicare Advantage, ACO, or other, to support an improved care model that can benefit your entire community. Jim?
Yeah, thank you, Amy, and certainly I believe Jonathan's with us today and probably spend some time with us on the Zoom breakout peer-to-peers after. So, just to double click on a few other things that I think Jonathan brings up. The audience today, we were lucky enough to have about 260 registered attendees. I'm guessing many of those probably wellness staff, nursing staff. 5 hours of time is the time that it takes for a member in need, a resident in need, to go out, to come back in, and then all of the administrative burden thereafter. I would actually say, having lived through this and operationally supported many of these community types, 5 hours is probably conservative to a degree. I think many of the communities probably in the audience today would say, hey, in my market, because the hospital may be far, or because the time it takes for us to even just make that determination with the family or with the care provider team takes a little bit longer. 5 hours is probably expanded pretty quickly. I think it's also important to note that if you're in the audience today and you're running a smaller operation, 5 hours, 6 hours, 7 hours, that's a full-time employee for a full shift. So when you really start to think about your operations in your community, the simple answer of the patient wasn't doing well, I needed to focus on my other X number of residents, 911 was the easier decision, probably doesn't have a lot of foresight. Now, don't get me wrong, I'm not a clinician, but there's probably lots of the right reasons that our members go to the hospital. But in those sort of cases where you would have a value-based care coordination team, it would be nice to have that backstop, nice to have that option, nice to be able to give that family and your wellness team, med tech team, caregiving team the option to say, you know what, I'm not going to be tied to this phone for 5 hours. I'm going to be doing all the other things that my other residents need. I think another point that's probably interesting there is a lot of communities have told me that patients go out and sometimes don't come back. So going out, coming back in 5 hours is one thing, going back and not returning is another. The disjointed care Jonathan mentioned, a lot of these patients have very tightly woven medication reconciliation and care plans that can quickly be undone by an emergency room physician and a physician in the hospital, all well-intended, but the dynamic of their care plans can get pretty well flipped. So I think that those are some really strong takeaways from Jonathan's point. And I think we also want to talk a little bit about the telehealth and the pandemic specific things.
Yeah, I think so. Just real quickly, pandemic-driven telehealth tech is really a staple of all of our lives now, and it certainly is a core component for value-based care. So whether it's video-enabled, it's telephonic, or I've even seen some newer kind of asynchronous consult-type models. And they certainly can improve access to care as well as support efficiency of healthcare delivery. However, it's also something that we've seen senior living operators kind of struggle with in terms of support. They've got multiple platforms, payment for facilitation of services, and also just access and training for their staff. So in the case of LifeSpire, telehealth is something that we were able to bring in to support their physician office visits, to make sure that they're safe and comfortable, so a big value add for families. But also that same platform supports care coordination activities that are paid for by the Medicare Advantage plan.
Well put, Amy, and thank you, Jonathan, for your contribution. We're going to go rapid fire here, so right into the next vignette. Tim Nelson, colleague I've known for a few years, has held various roles in that time frame through the Ensign Group, which he'll bring to bear in this video. So let's see what Tim has to say and how value-based care has impacted his partnerships in his community.
Hi, my name is Tim Nelson. I'm the Executive Director at Mountain View Retirement Village here in Tucson, Arizona. I'm part of the organization called Pinnacle Senior Living. Pinnacle Senior Living is also part of a larger organization called the Pinnacle Group, which recently spun off in the last 18 months or so from the Ensign Group. I've been with the organization for over 8 years. I started on the skilled nursing side as an Executive Director, and I've been with the assisted independent living side of our organization for the last 5+ years. We've been able to, over the last probably 3 years or so, been able to incorporate the value-based care system into our campus here. Even though I'm only the executive director of the independent assisted and memory care, we've been able to work very closely with the skilled nursing facilities on our campus, as well as with CareMore as a close partner for all of our communities. For us, we found value across the board. We've been able to retain our residents longer, give them a happier, healthier life while they're with us. And we've also been able to build even stronger community partnerships with our skilled nursing facilities and even with the hospitals and different local physician groups that also work with CareMore. Just in our community alone, we've been able to reduce our hospital readmissions by 62%. We went from, which was a decent number, about 16% hospital readmissions, down to 6.2%, which is obviously great on the business side of things, but even better on the care side of things, where we know that we're taking better care of the residents that entrust their care to us. We have a CareMore physician here in our building 4 to 5 days a week with some support staff as well. Their representatives are always here. They're at our events. They're helping us throw birthday parties for the residents, and they've really become a part of our community. And when residents come, or prospective residents come and their families to take tours of our community, we always make it a point to stop by the CareMore office and explain the benefits of having the on-site physician here for them. We've also been able to take on a higher level of care in our community. Here in Arizona, we can't do things like administer IVs or IV antibiotics or things of that nature to our residents. But having a physician here, we've actually set up their office in a way that they can actually give those IV treatments here in our community, so residents don't have to go out or go to skilled nursing to get that done. Going back to the rehospitalizations, we've been able to do direct admits from our assisted living and memory care, and sometimes even our independent living, straight to the skilled nursing facility and back to us. Another huge asset that this value-based model has brought to us here on this campus, one of our skilled nursing facilities has an outpatient clinic for physical therapy, occupational therapy, speech therapy. So we've been able to actually work with our in-house physician through CareMore to have our residents go to their outpatient clinic and come back without even having to be admitted to the skilled nursing facility. So being able to sell that kind of holistic package to residents, prospective residents and their families when they're touring with us and really investigating whether or not they want to come to our community has been a huge asset for us. So another amazing part of this partnership that we built with CareMore here at Mountain View Retirement Village and on this campus and across our organization here, at least within Tucson city limits, has been how our care staff has been able to interact with their care team from CareMore. They add a ton of value just by the simple fact that they're always available to us. We can call our providers and their support staff 24 hours a day, 7 days a week. So if we need a medication change, for instance, we can call them and get a telephone order right away. And if we really need them to, if they're not on site for some reason and we really need them to come, they will come and do an in-house visit here at the community with our residents. We recently here on our campus opened our memory care, and the CareMore team actually sent not just our physician that we normally have here on campus, but sent some other physicians that have the memory care expertise to come in to our community and train our staff. Having the families understand a little more about the diagnosis really does alleviate a lot of stress off not only our head of nursing, but the staff has been a huge asset to us here at Mountain View. It's been not perfect in the way we've executed everything, but having the partnership with a value-based care model such as CareMore, it really helps you build a relationship so that you can work through even the tough times and the little bumps in the road, and building that trust between the different organizations that we all touch, that they touch, and that we do really does add value to our business as a whole. And we look forward to continuing that for years to come.
Awesome. Well, thanks, Tim, for a great opinion and a great perspective. We're going to do like we did with Jonathan's and unpack that a little bit. I think I love the data-driven message that Tim is sending here. I think it carries over quite nicely from Jonathan's perspective on the time and the operational burden that it takes for hospitalizations, rehospitalizations, but to go from a stat which was already a bit better than national average in 16% down to 6% by best leveraging your value-based care partner, I think is exemplary. And I think that going into this new wave of post-pandemic consumerism, I think it's going to be fascinating with some of these local communities getting unusual questions during tours. I don't know that a family is going to, necessarily say, hey, what's your readmission rate? But I certainly think being able to tout that we have somebody to go to in case of emergency, and we can make sure that when you come back from that emergency, you're tucked in quite well is key. Amy, what did you gather?
Yeah, I love that the Mountain View team is showing off their on-site clinic. A lot of times we kind of see the clinic or the healthcare pieces tucked away or behind closed doors. I think as we are moving into post-COVID, this is something we're going to see more. We're going to see more of the healthcare. And so instead of the campus clinic and the clinical presence being thought of as something that, sometimes might detract maybe from senior living and an image of vitality and active lifestyles that we all want to portray, instead, it's going to be a selling point, offering safety, convenience, and peace of mind. So I think anything that we can do to quickly highlight that your community offers on-site healthcare in addition to hospitality services really is going to give residents, potential residents, and family members one more reason to move you to the top of their list.
Yeah, and the last point I think that's interesting to bring up is the way that their value-based care partner has infused themselves really into the fabric of the community. Supporting activities, supporting staff engagement exercises, being just a coordinator of relationships and references within the community, I think is so key. It really, if the primary value is going to be clinical, secondary value financial, the third value seems to really just be the culture and the shared philosophy. I also loved what Tim said about look, in some of your markets with you in the audience, you're held to certain state and or maybe even your operator restrictions on the types of care levels you're able to provide. Not encouraging the community to step out of its comfort zone, but rather bringing in an expert that can step right into theirs and keep you at a compliance level that's still above bar for what you want to do as an organization, I think is key. It'll allow that resident to, get infusion or sutures or wound care or a nebulizer there in the comfort of their own room versus having to go to that scary, unfortunate trip out that, again, we've already mentioned some of the mishaps that can occur there.
Yep.
So I think what I'd like to do is hear one more perspective. We invited Shane Connor, who's the VP of Senior Housing and Bull Realty, to join us. Shane, I think, brings a really great and unique perspective to this, in that he is an investor.
Hi, good afternoon. So my name is Shane Connor. I'm Vice President of Bull Realty Senior Housing and Healthcare Group, and we are a full-service national commercial real estate firm. And so in this space, we have owners, operators, investors, developers, and others with the real estate side of the business, whether that be selling, buying, capital markets work, kind of anything in between. And my experience with value-based care also stems from 8 years in the healthcare recruiting and workforce industry, where we did a lot of implementation and go live with a lot of these value-based care programs, staffing and placing clinicians that were going out into the senior housing communities. When we're talking about what is value-based care, I think from my perspective and my experiences, I think it's all about the alignment. And when I say alignment, obviously the financial incentives, aligning the payment model, but really, I think there's a big impact on the alignment of the actual clinical people themselves, because when you move away from the fee-for-service model, I think that speaks to really what value-based care tries to get to is what it should be. And it's just really about driving the outcome, not how many billable codes and fee-for-service transactions can we create. And so I think there's a couple different areas, that we look at explaining how does value-based care impact the senior housing space. The first one that we look at is kind of the recruitment and sales aspect from a resident. And I think this could not be more prevalent than ever coming out of COVID, right? Occupancy has been the looming question. When is occupancy going to come back? How quickly will it come back? And so I think if you're looking at opening these communities back up, especially in a very competitive marketplace where you've got a lot of communities, the prospective resident, and certainly their family are ever more aware of healthcare now than they have been with COVID. And so if you can show that your community either has an integration of value-based care yourselves, or you have, third-party partnerships, and I'm a prospective resident or the adult child, and I've got 5 options that we're looking at, and one's got a value-based care integration. They can show me their outcomes, they can show me their data, and the 4 other in that market don't. I think it's a pretty strong case of where I'm going to move in or where I'm going to move my mom to. So I think from a leasing backup and a occupancy on the front end, value-based care is going to drive a lot of that. And whoever's doing it now, I think will probably take the early lead in rebounding occupancy. The second area that we're looking at is really the staying in the bed, right? So keeping people healthy and keeping occupancy strong once you've got it. That becomes most prevalent as people's acuity changes. If you're in a standalone environment, the worst thing that you can have for your bottom line and your financials is people moving up the acuity curve. So moving maybe out of your standalone IL because they need to go to AL, or out of your AL to SNF because their needs have gotten too high. So if you've got a value-based care integration and a partner that's either bringing resources on site or helping you create those programs, that's going to help you keep people in the bed and not moving to the next chain of acuity in that senior housing curve. And obviously that's going to translate to better financials, better performance. And then the third point would really be the staffing piece itself. I think we talked about a little bit, that's where I had a lot of experience back in the day when we would deploy these clinicians, these road warriors that would be out traveling to the communities. And that can really help offset community level staffing because it takes some of the burden off the higher acuity patients or the day-to-day staff when they know they have this members, surrounding clinician, whether it be an advanced provider or just an RN who's going to be coming on site to help manage some of the more complex patients, and you can offset some of that cost. And then the fourth part that we really look at, and this is probably where I wear the hat mostly now on the investor side, helping from the real estate component. Investors, when you're evaluating a transaction or you're evaluating potentially an operator for them taking over a building, you're really worried about, can they meet these projections? Can they meet the pro forma? And at the end of the day, can they hold this occupancy? And so if you're evaluating a group that implements value-based care or is embracing value-based care, you're going to be more confident that they're going to keep people healthy and keep those beds full. And then from a valuation standpoint, if I've maybe held this facility for 5 or 6 years and we can show the impact that the value-based integration had on the occupancy, on the bottom line financials, then when I go to take that out to market for another prospective buyer, you may be able to command a higher dollar and a higher valuation because this particular community has such a good value-based model integrated as compared to maybe somebody, one of their competitive communities in that market that doesn't. And you can make that very, very apples to apples correlation.
All right. Wow. I really like Shane's investor perspective here. And Jim, I feel like we're starting to venture a little into fall NIC conference territory. So neither Jim nor I are an expert in the investor and valuation side of the industry. We're both more focused on the care and care delivery models. So it's refreshing and I think validating in many ways to hear that care really can add bottom line value. So I know that Shane does have a background in developing primary care models to support value-based payment. So he's probably a little more attuned to the benefits than maybe I'm going to say the average senior housing investor. However, I think he makes a pretty good case that when successful, value-based care partnerships can directly impact occupancy, return to capacity, and the value of a community on the open market. So as we heard from, Jonathan and Tim, senior housing can bring in care partners that bring new or additional clinical capabilities and services. And these relationships don't have to cost senior living operators really anything. And in many cases, they can help save dollars, again, just like we've been hearing. So to add in Shane's perspective that value-based care participation can increase the bottom line value of your campus or portfolio, I think is pretty compelling. We're seeing also this kind of trend across the healthcare industry. When I look out there, there's clear evidence that healthcare investors are attaching real dollars to value-based contracts held by all types of providers. Organizations that can demonstrate the ability to positively impact healthcare outcomes and successfully manage costs for a specific population are earning top dollar. You can go out there, Google these. You're going to see some really high valuations, especially for physician groups around this. So the interesting part, I think, for senior living operators is that participating in value-based care as an ALF, a CCRC, or even a SNF does not mean that you have to take risk. So you might want to, if you're leveraging existing capabilities, like Jonathan talked about transitional programs. So you might want to take on some of that risk and some additional payments associated on outcomes. But you can also bring in the value that risk partnerships help fund through strategic relationships with other healthcare providers. And Jim, I know both of us have some real examples of this, but one of the things that I think about is the leasing backup and rebounding occupancy that operators are really focused on right now. And investors want to be part of thriving and full communities. That equals rent and longevity. So communities with value-based, clinical infrastructure are just better equipped, I think, both to attract new residents by offering more, but also to keep existing. And you talked about this just a minute ago in keeping people on campus for as long as possible and as safely as possible. So I think in a post-COVID environment, when many operators are struggling with occupancy, value-based care relationships seem to make a lot of sense. What are your thoughts?
Yeah, I mean, you hit on so many great points, as does Shane. I think the first thing is, and we'll close with some of this as well, but sometimes I talk to operators that just feel like this is such a long runway, that this is such a huge commitment, that this takes a lot of capital. And the reality is it does not. There's phased approaches, and we're going to get into some of that, and I hope to in the breakouts as well. The other thing I just love that Shane and you touch on is the reality of the investor perspective is that, in chaotic times especially, they're looking for confident and sustainable financials for future success. And a lot of times when they're evaluating these communities, it's of course based on occupancy. It's of course based on the competitive landscape in the market. It's of course based on the staffing, because that's such a huge cost of the day-to-day operations. I'll tell you a quick story. You know, when I was leading the CareMore solution, we had this great report called a durational analysis, which showed us the longevity and how well our patients did as time went on within our program. What it also showed us when we pared it down by community was the length of stay of our members in select communities. We did about a 10-year study with one of the largest national operators out there, where we supported around 35 of their campuses in 4 states. And their average length of stay was something like 22 months. This is in your standard assisted living community. Our average length of stay between the time a member enrolled on our program and then either had to move to a higher level of care or unfortunately passed away, natural causes, was put on hospice, was about 40 months. So almost a 100% change. So from 22 months to 40 months was the length of stay. And that was, again, their data, their control group, but yet we saw that the ability for that member on that campus to enroll in value-based care solutions increased their length of stay. Real quickly before we close, I also just thought, you know, Shane did a great job, but offsetting staffing costs is something key here. There were lots of times where because of the amount of enrollment we would get in a community, not only would we have what Tim and Jonathan mentioned with that physician and practitioner on campus, but we would have pharmacists go to the campus. We would have medical assistants be deployed. We would have lots and lots of additional solutions, which allowed that community to potentially offset their staffing ratios. The other thing I think that's a part of this maybe secondary or soft suite of value-based care solutions are things like your value-based care partners can refer move-ins. They can lease space themselves. They can fuel your secondary programs. If you're an operator that also has investment in home health and hospice and caregiving, great referral partner. And lastly, many of these communities we partner with have levels of care. You've got independent to assisted to memory, as Jonathan's community does. Sometimes it's hard for the community alone to stand their ground on telling a patient and a family, yes, you've met that sort of threshold of care, you do need this. Yes, it's going to cost you this extra, but. So it's nice to also have that value-based care partner on your side that's also seeing just the clinical needs of these patients alone evolve. So we've come to the conclusion of our vignettes and our chat, Amy. It's been a lot of fun. Why don't we take a few moments, just bring it all together, close things out, and then move over to Zoom here quickly.
Yeah, a big thanks to all 3 of our video presenters today, Jonathan, Tim, and Shane, for sharing their experience and insights. I think there were some common themes. Hopefully the audience was able to pick up on those. I do look forward to continuing the discussion as we move into some of the breakout groups. For me, near and dear to my heart always, and what I heard is that, you know, each of these presentations discussed partnerships. And in Jonathan and Tim's cases, specifically primary care group relationships. So this has been, again, another discussion topic, ongoing discussion for the past couple of years at the NIC spring conferences. And I think it makes a lot of sense to start a value-based care strategy with a partnership strategy. Because in senior living, we need the care partnerships to fully deliver value to residents and to fully benefit from the value of optimized care and cost outcomes. So I think the good news right now, going back to our discussion a few minutes ago related to investor valuations, many physician groups are seeking ways to actively move from fee-for-service and to participate in more value-based care models and value-based payment or quality payment models. So I think that senior housing groups are going to find it a little bit easier in the coming days to identify physician or primary care groups who can bring along a value-based payer with them. And that allows the physicians to offer more services on your campus, but also allows you to enjoy some of the benefits and efficiencies you heard from Tim and Jonathan. Something else that I see quite a bit as a payer when we are approaching senior housing organizations is I hear that, well, we've got a strong medical director, we have some good primary care practices, but we'd really like to see more of them, or we want more of these care coordination services that we've talked about today. And so I would suggest that this is a great opportunity for you as a senior housing operator to think about working with one or more of your existing primary care teams and basically jointly recruit a value-based payer or a contract with a Medicare Advantage organization or ACO. So I think there's a lot of opportunities, not a single right fit for everybody, but I think they will continue to grow. Jim, anything else before we start wrapping it up?
Yeah, I think those are great takeaways and similar themes amongst the others. I'll keep mine sort of relatively short and sweet here, and that is that just remember, this is not a binary decision. Going to value-based care solutions on your campus is not mutually exclusive to that being the sole all-in-one solution that you're prepared to embark on. It's unrealistic. Patients deserve choice. But think about value as a trial. Think about value as staggering your start in which to align with the government or your local communities or your own organization's philosophical approach. Test, be curious. Think about shared savings kind of agreements and or bundles and or working with ACOs or direct contracting entities before you start to embark on percent of premium and risk deals and forming your own sort of value-based care org. So again, there's lots of support that value can mean. There's lots of definitions for value. And the last thing I think I'd say, just as we welcome Chuck back in, is that remember the topic today was what's in it for me. So this was very much a discussion around the value to you, the senior living operator, owner, investor, physician group who may be in the audience. But remember that patients are at the center of this too. And we all got into healthcare for different reasons. We've all stayed in it for different reasons, but I truly believe in my heart of hearts that anybody that stays in this industry does so because they've got a heart for patients and care and access and futures of bringing more value and less waste to our seniors. So keep doing that for the residents. There's lots of perks that come along the way for them in value-based care type arrangements too, in the form of benefits and simpler paths to the right care at the right time. So thank you all.
Amy, Jim, many thanks for co-hosting today's webinar, and thank you to Jonathan Cook, Tim Nelson, and Shane Connor for sharing your approaches to providing healthcare services as part of your overall value proposition. As a few seats remain for our Zoom chat following today's Leadership Huddle webinar, if you're able to join us, you're welcome to click on the Zoom link, which is now posted in this webinar's chat. The Zoom group discussion will begin shortly at 2:50 Eastern. We welcome everyone to join us again 3 weeks from today on Wednesday, April 14 at 2 p.m. Eastern, 11 Pacific, for our next NIC Leadership Huddle titled Skilled Nursing Integration, Will COVID Be the Catalyst for Tighter Hospital Partnerships? The upcoming webinar will feature a conversation with healthcare system executives about the value of joint venture partnerships with skilled nursing operator companies. On behalf of the National Investment Center for Seniors Housing and Care, thank you again to Lumen for sponsoring today's Leadership Huddle. It's through sponsors such as Lumen that in large part, NIC can provide a forum for education and discussion such as this, and thereby help to enhance transparency, facilitate the efficient flow of capital in seniors housing and skilled nursing, and support access and choice for older adults. This concludes the webinar portion of today's Leadership Huddle.